the basic test and do the initial treatment. If it's a nephropathy, we can manage the disease to some extent by our own with all the available drugs. And if it's a cardiovascular disease, the physicians are able to manage to some extent. At least the primary prevention we are able to do to some extent, and early diagnosis can be done. But when it comes to retinopathy, most of us are blind. So unless we opinion from the ophthalmologist by routine screening and early detection, we might miss on the retinopathy, and it needs the expertise of an experienced ophthalmologist to manage patients with retinopathy and to prevent the complications of blindness. So rightly we have the right speaker to deal with that. I will be just introducing the chairpersons and the speaker, and then handing over the session to the chairpersons over the next couple of in the next couple of minutes. So we have two esteemed and experienced chairpersons with us. So it's my honor to welcome Dr. Tangam, who is a very senior physician from Trivandrum. She is currently working as the consultant in medicine and diabetology at SK Hospital, Trivandrum. She has a vast experience of more than 35 years in the field of internal medicine. She has held various positions like Associate Professor of Medicine. She has been the Nodal Officer for NCDs, cardiovascular disease and stroke. She has also been the additional director of health services, and she has also been in charge of the state's AIDS program. And she has retired as the additional director of health services. And she also holds membership in all the leading associations. She has been very much active in the women's wing of IMA, and she has organized many programs with respect to the IMA and women's health. And she has also received the Diabetes Awareness Award at the Diabetes India Conference in Bangalore in 2020. She is conducting monthly camps and awareness classes for the past many years. And she has also conducted more than 1,000 camps, several television awareness programs in several channels, Samuhya Padam and the Kutugari program in Doordarshan channel. So we have Dr. Tangam, who is a very senior and experienced physician who is going to chair this session for us. Along with that, I would like to welcome another a very senior and experienced physician who is Dr. Rajalakshmi, who is again working as a consultant diabetologist and podiatrist in Bernard Hospital and Arya Diabetic Center in Trivandrum. She again has got a working experience of more than 25 years. She has graduated from MS Ramaya Medical College. She also has got a fellowship in diabetology and has her DNB in internal medicine. And she also has got a fellowship in podiatry, and her areas of interest include activities in diabetes awareness, and she's particularly interested in diabetic foot care. She is also the member of RSSDI, Diabetes India, and the leading societies like the Diabetic Foot Society of India and the Indian Podiatric Association. And finally, I will be introducing the most important person of the day, Dr. Gopal S. Pillai, who is our speaker, and is a well-known figure across the state and across the country. He is currently the professor and HOD of ophthalmology of Amrita Institute of Medical Sciences, Kochi. As you can see, he has got plenty of academic publications at national and international level. He has got a lot of public health activities, and he's a pioneer in small gauge sutureless vitrectomy surgery in India. He is a reviewer of multiple journals, and he's also the General Secretary of Kerala Society of Ophthalmologic Surgeons, and is also the organizing secretary of the All India Ophthalmological Society Conference in 2023. He's also the member of the National Task Force of Government of India in Diabetic Retinopathy and of the Optometry Curriculum Development. He is also the member of the National Institute of Empowering People with Multiple Disabilities, and he is also the leading investigator in the Clinical Trial Network in Ophthalmology and National Registry. So with this, I will stop the introductory slide and hand over the session to the chairpersons to carry forward from here.
Thank you, Dr. Prashant, for the nice words. First of all, I thank the organizers for giving me the opportunity to share the session. As a part of Diabetes Crossroads, the 6th episode is Diabetes and I. We all know the complications of diabetes as macrovascular and microvascular. Among that, retinopathy is one of the most important complications. And today we got an eminent speaker, Dr. Gopal S. Pillai, Professor and Head of Department of Ophthalmic Department, Amrita Hospital, Kochi. Now we can hear from him about the diabetes and eye. Over to you, Dr. Gopal.
Thank you very much, ma'am, and thank you very much, Dr. Prashant, for the kind words. I first of all thank Dr. Suresh Kumar, Anita Nambiar, ma'am, and all the others present here for having given me an opportunity to be amongst you and to interact with you, giants in this field of diabetes. So first of all, let me say that diabetes affects each and every cell in the human body. We all know that. So it is very superfluous to say that it would just affect the retina. It affects right from the lids to the cornea, to the lens, to the intraocular pressure mechanism, to actually the retina and the optic nerve. So every part of the eye is involved as in diabetes. So what are the common problems which can occur in the lids? It's very common. You can have some boils like hordeolum externum or hordeolum internum. These are styes. And these are very common in diabetic people. There will be some small swollen reddish lesions in the lid margins, with which the patient may come to you. And most of them will just require some topical antibiotics until and unless it moves more into the periorbital space and cause periorbital cellulitis or something like that, where you may require systemic antibiotics. Very rarely they may require to be incised and curated or something like that. Now, coming on to the cornea. The cornea is the most transparent outer layer of the eye, and there is the epithelium, which is on top of the cornea. There is a connection between the epithelium and the basement membrane, which is a little loose in diabetics. In all the other, so a small trivial trauma can cause what is called an epithelial defect. And these diabetic people, as you know, are susceptible to infection. And so a trivial trauma to the diabetic eye can finally lead to a corneal ulcer. So again, that is another major problem which can occur in diabetes. So corneal epithelium is very fragile in diabetes. That is number two. So we told about lid, then we told about cornea. Next thing in cornea is possibility of dry eye. So dry eye is a very, very common symptom, especially post 50 and 60, and on people who are long time on devices or computers. So what happens is that when the eye is dry, the basal secretion of the tears reduces, and that causes reflex tearing. So it's a paradox that the patient will say, there's a lot of tears coming out of my eye, and you are telling, oh yes, this is called dry eye. So it's a total paradox. So the patient will be thinking that, why is the doctor telling it's dry eye? Because it's always tearing. So it's a tears which are reflex tears which are coming out. So that is dryness. Next, we come into one of the most important areas called the lens. So diabetic patients have got a propensity for developing earlier cataracts. And usually the cataract in diabetes is called a snowstorm cataract. So what happens here is, so instead of about 60 years of age, probably by about 40, 45 years of age, some of these patients can develop cataract. And you can see that cataract surgery has been revolutionized completely. And there are surgeons who are operating 10 to 12 cataract surgeries in an hour, which means 5 minutes per cataract surgery. There are surgeons like that. So, but having said that, to reach that stage requires a lot of finesse and a lot of effort to reach there. But not trivializing cataract surgery, you should never do that because patients finally are undergoing a surgery. Okay, and anything can go wrong, and actually a lot of problems can occur. But what I wanted to say was diabetics will develop a cataract much earlier than usual. Then you have the extraocular muscles. Okay, so diabetic mononeuropathy is a very common thing. So it's often that, after 10 years of diabetes, 15 years of diabetes, suddenly a person develops a diplopia and comes to you. And when you look at it, the lateral rectus is not moving. So that's a very common thing. So lateral rectus paresis or palsy can occur. And even third nerve palsy can occur in a diabetic patient, which usually in our 80% of patients, it will resolve in about, let us say, 2 to 3 months, usually. So then we move on to the back of the eye, which is the retina, in which significant retinopathy can come and you can have permanent loss of vision. So permanent loss of vision, one of the most important reasons would be diabetic retinopathy. And diabetic retinopathy is one thing. Unlike all the other things, it is as the duration of diabetes increases, the gradation of diabetic retinopathy also increases. So it can be used as a surrogate biomarker to see how long the diabetes is and how severe is the end organ affection in a lot of other places. All right, so that is about diabetic retinopathy. Now moving on to the optic nerve, sudden vascular compromise to the optic nerve called ischemic optic neuropathy can actually very suddenly cause a loss of vision. So this is how, in a nutshell, you can see that from the anterior part to the posterior part, all structures of the eye can be involved by diabetes. Now let us move to some of the cases where I want you to, pardon me? Yeah. So somebody was telling here, Suresh sir was telling that, or Prashant sir was telling that we don't have a clue about diabetic retinopathy. Absolutely not. I think you should, because direct ophthalmoscope, now a pocket direct ophthalmoscope costs 3,000 rupees, 3,000 or 4,000 rupees. And in 1 month, you will be able to train yourself to see the macula and all around that area. It's so simple. So it just takes a little bit of an effort. And do you know what all you are seeing? The only place in the whole human body where you can see the nerve, you can see the optic nerve. The only place in the whole human body where you can, we are all dark skinned people. Our skin doesn't show that much vessels. The only place in the whole human body where you can actually see the blood vessels, the arteries, the veins, and the internal milieu in it, which is back then. So all the hypersensitivity reaction, all the vasculitis and the vasculopathies, all the generalized neurological problem, you can depict right from the eye with this 3,000, 4,000 rupees small handheld direct ophthalmoscope, with which you will be able to do it at will. The only thing is you should have the will to do that. Okay, now let me move to my presentation. I have basically packed some cases. Let us just move on to these cases. Oh, I can use the pointer. Pointer would be a little better idea. Yeah, okay. So this is a patient who is 5 years diabetes. There is no diabetic retinopathy on examination and poor systemic control. This is a patient who usually comes to you or to us. I mean, when you are seeing the diabetic, can you see these images? Is my screen visible now?
Yes, sir. Yes, sir.
Yeah. This is the optic nerve. I would just like to, for people who have this is the optic nerve. This is the left eye, and this thinner one is the vein, and the thicker one is the thinner one is the artery, and the thicker one is the vein. This dark one is the vein, and the thinner one is the artery. Okay, now this is a patient in whom there are all these vessels are normal. There are no additional things. So what are the additional things which can develop? I will come to each of the additional thing as it comes. This patient does not have any diabetic retinopathy, which means that the patient does not you cannot honestly say some patients who have 25-30 years of diabetes also do not have diabetic retinopathy, may not have, but that is an exception. Generally, by about 10 years of diabetic life, they start getting diabetic retinopathy. By 15 years of diabetic life, they start moving into moderate diabetic retinopathy or clinically significant macular edema, etc. And by 20 years of diabetes, they move towards a stage called proliferative diabetic retinopathy, in which bleeding and traction retinal detachments do occur. So this is these diabetic values are not so good. Hemoglobin A1C is 9.1. So this is an opportunity for you actually. So you actually do not know, as a diabetologist, you do not know, how, because this 5 years of diabetes is his version. It may be 15 or 20 or 25 years of diabetes. And when I went to some North India for some camps, I found out that when I asked whether you have sugar ka bimari or sugar ka bimari or chini ka bimari, they are not even aware that there is a bimari called diabetes. Okay, so it's as poor in many of these places. So you should always take a fundus picture. Now, short of the diabetic retinopathy evaluation with a direct ophthalmoscope, we have now a lot of non-mydriatic cameras which are available, which are AI enabled also, which are FDA approved or approved, and we can take a picture. What is the cost of such cameras? About 4 to 5 lakhs rupees. So if you have some 20-25 people, you can every day which you are seeing with diabetes, you can just take a click on the camera and they will tell you, the AI in the camera will basically tell you whether there is diabetic retinopathy, whether there is clinically significant macular edema, whether there is proliferative diabetic retinopathy, whether this patient requires referral or not. So if a printer is connected to that, you can give images to the patient straight away. The point I want to make is you have to distinguish between people who have diabetic retinopathy significantly and do not have diabetic retinopathy significantly. Because in patients who do not have diabetic retinopathy, you can be very, very severe in your diabetic control. You can control really well. In patients who have a significant diabetic retinopathy, in the first year of diabetic control, especially if you're going for a tighter control, there will be some worsening of diabetic retinopathy and maybe some decrease of vision. So if you differentiate them into people who do not have diabetic retinopathy and people who have diabetic retinopathy, probably your control can be much more aggressive in patients who do not have diabetic retinopathy. So diagnosing DR is with the direct ophthalmoscope or with a non-mydriatic camera for you. And you need to counsel that if there is a pathology, if you're seeing some abnormality, definitely yes, you should be seeing an ophthalmologist. Most of our patients who come quite late have been unfortunately on diabetic treatment with some physician over the last 15-20 years, but he has never ever actually asked the patient to go to an ophthalmologist because the patient never complained of a decrease of vision. So when will the patient complain of decrease of vision? The patient will complain about decrease of vision only very late in the course of diabetic retinopathy. So for 20 years, the diabetes will move from mild diabetic retinopathy to moderate diabetic retinopathy to severe diabetic retinopathy to very severe diabetic retinopathy to proliferative diabetic retinopathy with good 6/6 vision. 6/6 is the normal vision. And then the vision will start dropping at that point of time. And by that time, you are into end-stage diabetic retinopathy. That is a point of time when many times vision drops slowly or suddenly it will drop because of a bleed or a traction retinal detachment. But at that point of time, if the physician refers, then the usual treatment that we have is probably a surgical treatment, which is not very good. So if you are able to actually pick up this patient in a very severe or a severe non-proliferative stage, then probably you could do laser injections, etc., and actually make the patient better. Now you can see in this patient, can you see some yellow spots here and there? This is what is called a soft exudate. We have more soft exudate pictures coming up, so I will show you. And these are small yellow spots are hard exudates. So here are also some yellow spots here. This disc is slightly edematous. You can see that these vessels are slightly more tortuous. And whenever we have more tortuosity, this patient also has 6/6 vision. But in contrast to the previous patient that we saw, here this patient, the veins and the arteries are a bit especially the veins are a bit dilated, which tells me that this is a progressing diabetic retinopathy. These are patients who are progressing, and these are patients in whom you need to follow up more carefully. Again, first thing is about good systemic control, but just understand that just good systemic control will actually reverse some amount of diabetic retinopathy, but it will be a good idea to keep along with your good tight control of diabetes, let an ophthalmologist also evaluate, so that we will be able to also help in the management of these patients. So as I said, strict or ordinary, the DCCT and the UKPDS already gave us the answer. DCCT, you can understand about the memory effect that it had after about 20 years of stopping the trials. So systemic control, if it is strict, it is very good. But if there is already some advanced diabetic retinopathy, it becomes a little difficult to make a very strict diabetic retinopathy. Follow-ups with the ophthalmologist depends on the stage of retinopathy. If it is very mild diabetic retinopathy or not diabetic retinopathy, we will follow them once in a year only. But if it is about moderate, then we'll follow up about 6 monthly. And severe, very severe PDR and all, when we start treating, we'll follow them more frequently, maybe monthly or 2 monthly or 3 monthly. In diabetic macular edema, usually what we will do is that you will keep injecting and follow them up monthly. Now we will go to another important thing. See, this is a cataract. So you can see that this is a dilated pupil, and these black things are basically an opacity in the lens. So this is a cataract. Can you see that the center is also involved? Because the center is involved, you can see that this image is a little hazy. Unlike the previous images, you can see the disc and the vessels a little hazily through the cataract. Now, this is a patient with cataract. Now, this is a patient in whom cataract surgery is required. But in the presence of diabetic retinopathy, what we should always do is we should evaluate how much is the retinopathy. Basically, because of the cataract, we will not be able to see the retina properly. And so we may require some ancillary investigations like fluorescent angiography and OCT to actually pick up if there is an edema or if there is a neovascularization. And then based on that, treat the retina and then consider doing the cataract. What happens sometimes is, this is a cataract, again with moderate NPDR, but this patient underwent cataract surgery, but he was lost to follow-up for 6 months. When the patient came back, he came back with a vitreous hemorrhage. You can see that this is the cataract, and this is a very well done cataract surgery without any problem. The central lens is very clear, and this was the retinopathy before that. And after this, you can see that you have a vitreous hemorrhage. Why did this happen? This is because this patient at that point of time may have had a proliferative diabetic retinopathy, and usually cataract surgery progresses the diabetic retinopathy. So because the cataract surgery progresses the retinopathy, it is often a better method to evaluate the retinopathy, treat the retinopathy, make sure that it is stable, and then do the cataract surgery. And after cataract surgery, we will require to follow up these patients and see whether retinopathy is progressing faster. Otherwise, these patients will come with us with a loss of vision, like a vitreous hemorrhage or something like that. So now let us come to this particular picture. This patient also has nephropathy. Okay, you can see that multiple whitish lesions are there. So can you differentiate these yellow dots here, these brighter yellowish dots here, to these whitish lesions? These are called cotton wool spots or soft exudates, whereas these are called hard exudates. Hard exudates are cholesterol deposits, whereas soft exudates are because of the ischemia of the vessels. What happens is there will be infarction of the most superficial layer of the retina called the nerve fiber layer. And because the nerve fiber layer is infarcted, it will look like cotton wool spots. And so these are cholesterol spots, cholesterol dots, and these are because of ischemia. So this is a patient with nephropathy. So this patient probably has very high hypertension, and hypertensive retinopathy can also present with a lot of soft exudates. So hard exudates, if you remember from your MBBS, are a feature of diabetic retinopathy, and soft exudates predominantly is a feature of hypertensive retinopathy. So both can coexist. Diabetes as well as hypertension can coexist in a lot of people, and uncontrolled diabetes and hypertension leads to a mixed retinopathy type of a picture in which these are there. All right, these soft exudates as well as hard exudates, as well as you can see the arterial attenuation. The arteries are thread-like. So arterial attenuation tells us that the hypertension is very active. And along with that, there are some hard exudates in the center, which tells us that there is diabetic retinopathy as well. Now, these are more severe changes. You can see all across there are multiple hemorrhages which has occurred, and yellow colored, drusen's and hard exudates and all those in different areas. And there's a small neovascular network which is developing here. So these are all more severe changes, severe to very severe non-proliferative diabetic retinopathy. As this retinal severity increase, we will require to do, as I said, a couple of tests. One is called a fluorescent angiography. You inject a dye called sodium fluorescent 2% into the antecubital vein and take pictures. This is fluorescent angiography. And then the other test obviously is called an optical coherence tomography, which is a laser beam which will be sent. It is just like an ultrasound using a laser. So you are sending a laser beam, and then all the reflected images are taken and amplified, and it is reconstructed. The only thing is you require a transparent media for the laser to go in, unlike in an ultrasound, which can go through an opaque media as well. So these are fluorescent angiography. You can see that this is an innocuous looking diabetic retinopathy. If you look at a direct ophthalmoscope, probably this particular area will look completely normal. But you can see the fluorescent angiography shows fluffy white leakages These leakages are called neovascularizations. So these are neovascularizations. Now this is again, you can see this is a central fovea. This is a central fovea. Since the fovea is not involved with hard exudates or edema, actually the vision in these patients, both the eyes is 6/6. Okay, but these hard exudates are here, which are very close to the fovea. If you do not do anything about that, it will just invade the fovea and cause irreversible loss of vision. So this is a point of time when hard exudates or thickening or retinal edema is away from the fovea. You can consider doing laser to those areas which are leaking, and that will cause complete resolution of the hard exudates. So these are these patients. You can see there's mild edema here on just temporal to the fovea. And you can see that after focal macular laser, I had done focal macular laser, and you can see that over 1 year, the patient is maintaining 6/6, and these yellow colored hard exudates have reduced here. And this particular eye, it is almost disappeared. So this is how post-focal macular laser actually does wonders when the hard exudates and the thickening is away from the fovea. But at the fovea, you cannot laser. So if the hard exudates or the retinal edema involves the central macular edema, central part of the retina or the fovea or the macula, then it's a little difficult to laser that area. In those cases, you may require to go for injections. So this is again another case in which you can see that retinal thickening is there. You can see some hard exudates, some yellow colored hard exudates, cholesterol deposits are there. Post-treatment, you can see that it is completely reduced. All right. Again, this is another case in which post-cataract surgery, the patient was seen only after 3 months. You can see this hard exudate. You can see the retinal image has become a little more clearer here because after cataract surgery, it's brighter. But you can see that the hard exudates have progressed and vision has reduced from about 85% to about 60% in these 3 months. So just a cataract surgery can actually improve the vision in a lot of patients. But in a diabetic patient who is going to progress, it can actually cause a lot of problems. So before cataract surgery also, we need to actually look at this and find out. So this is an OCT image which tells us that there is an edema. Normal OCT will look something like I showed you before. This would be a normal OCT. You can see a central foveal, you can see a dip in the central fovea. Whereas now when that dip is gone, you get what is called an edema. So there are different types of edema. One of the most common edema is this, which is called spongy macular edema. And there are other types of edemas as well, in which you can see that this patient underwent multiple antivascular endothelial growth factor injections. So I told you that one of the important treatment modalities that we have is laser. The other important treatment modality that we have is injections. So they are anti-VEGF injections. There are different anti-VEGF injections. The most common one, the most cheapest one that we use is called Avastin or bevacizumab. Avastin is a basic drug which is designed to treat colorectal cancer, but serendipity had Phil Rosenfeld, a US doctor. He looked at Avastin and the structure of ranibizumab. He was also involved in ranibizumab, the drug generation. So when he looked at the chemical structures of both, he found that it was almost similar and the active ingredient was almost the same. So he tried using bevacizumab in these patients and it was very successful. And that is how Avastin came in. Avastin is much cheaper than ranibizumab. So then the next drug is aflibercept, which is called Eylea. Ranibizumab is otherwise called Accentrix in India. And then we have a new drug anti-VEGF called Paganex. We also have a couple of steroids. One is triamcinolone and the other one is dexamethasone slow-release implant. These are the armamentarium that we have to treat the eye. All right. So when there is a lot of edema like this, hard exudates like this, and huge edema like this, we consider doing injections. So how do you consider injections? Mostly we start with anti-VEGF unless there is a recent history of stroke, heart attack, progressive nephropathy, etc., in which we may consider steroids as the first form of treatment. And usually we may require multiple anti-VEGF initially in a diabetic macular edema to stabilize it and improve the vision. So what is a treatment result of diabetic macular edema? So patients with diabetic macular edema who had close to 60 or 70% vision, if you treat religiously, if you treat really well, actually with there is a large study from the diabetic retinopathy network. So that's called drcr.net, Diabetic Retinopathy Clinical Network. That is in the US. About 50 hospitals are there. So they looked at about 1,500 patients and found out that in the first year, they required close to 9 injections in the first year. In the second year, they required somewhere around 4 injections only. In the third year, they required 2. And the fourth year, they required 0. And the fifth year, they required 0 number of injections. Why did the number of injections come down? Because diabetic physicians as good as you actually control the diabetes so well that by the second year, their need for injections actually reduced. So these are patients in whom you have multiple anti-VEGF and followed by focal macular laser. You can see that the thick hard exudates have reduced significantly here. And this is the fovea, which is now almost better. And you can see the edema here is also reduced significantly. So sometimes you may require repeat focal macular laser after the edema comes down. And this is such a patient in whom repeat focal macular laser had done. And from 80-85%, it improved about 90%. You can see this final edema also changed in that patient. Now, whenever the patient has other problems as well, like he has an amputated foot, it is very difficult for him to travel again and again and again monthly. That would be a situation. So as I said, if you have recent heart attack or stroke, which are thromboembolic phenomena, or we have a progressing nephropathy, or we have a patient who is very difficult to travel, these are patients in whom you may consider using long-acting implants. So long-acting implants is what we will usually do. Okay. Dr. Abhilash. Okay, so anti-VEGF versus intravitreal Ozurdex. These are for ophthalmologists. Okay, this is a hard exudate plaque. So you can see that the yellow central plaque. This plaque will not go away. You can see on the OCT, you can see underneath the retina, there is a reddish plaque, and these plaques will not go away with injections. So you are only going to treat the surrounding retina. If the surrounding retina has any problem, then you may consider treating that. That's all. Now, macular ischemia is another problem. On fluorescent angiography, you can see the central area is completely devoid of those, background fluorescence, which tells me that this is a central area with a lot of ischemia. So ischemia can also cause a decrease of vision as much as edema. So in patients with ischemia plus edema, why is it that some patients whom you treat improve to 100% vision, whereas some patients don't improve? That's basically because even if you are able to completely control the edema and bring it back to complete normalcy, because of the ischemia of the retina, a lot of cells would already have been damaged. And this damage is irreversible. And that is why macular ischemia, finding out macular ischemia is an important factor. Next important thing is, now all that area of edema may not be amenable to injections or laser. There will be some cases in which there is a structural problem here. This is a patient who has a traction. So retina is under traction, just like your shirt, you're pulling it out, or somebody is pulling out something out. So this is a traction here. So this is manageable only by surgery, by cutting off this traction, which is pulling the retina. Then it will fall back and this particular thing will be all right. Now, this is a taut posterior hyaloid. Let me not go into that. So this is the next stage of diabetic retinopathy, wherein this patient presents with florid neovascularization. So why does neovascularization occur in diabetic retinopathy? Basic problem is ischemia. The central theme of diabetic retinopathy is ischemia. Why does ischemia occur? Because all the blood vessels get slowly occluded by a lot of pathological processes in diabetic retinopathy. There will be loss of pericytes. There will be a lot of inside. There will be a lot of thickening of the endothelium. All this will actually cause occlusion of these vessels. Not complete occlusion, but it will be lumen will be very narrow, and this will cause ischemia. And because the cells are ischemic, cells will produce vascular endothelial growth factor, because hypoxia will produce vascular endothelial growth factor. This vascular endothelial growth factor will trigger the formation of new endothelium and endothelial line tubes, which does not have tunica, intima, media, adventitia. It only has endothelial line tubes, and that is why these are leaking profusely. And because they do not have intima or tunica media or tunica adventitia, These vessels, whenever you cough or sneeze or do some activity, or maybe lift some heavy weight or fall down from a place, it suddenly ruptures and bleeds and causes loss of vision. So proliferative diabetic retinopathy, if you look at patients with proliferative diabetic retinopathy, about 75 to 80% of them will have nephropathy as well. Okay, so it's a surrogate biomarker to find out nephropathy. So proliferative diabetic retinopathy is equal to nephropathy. So that is what we will understand. So this is a neovascularization, and this is how you would laser a neovascularization. A lasered neovascularization slowly regresses, and these new blood vessels will slowly fibrose. That is called an angiofibrotic switch, which actually causes fibrosis and scarring. Once the scarring occurs, this tissue will never bleed. So that is why a laser is always done, a pan-retinal photocoagulation is always done in a patient with proliferative diabetic retinopathy. This is a patient in whom you can see almost normal looking retina, but you can see that multiple neovascularizations are there here and there. And this is a patient in whom you may require injection followed by laser. You can see this is an eye in which there has been a lot of neovascularization, and you can see it has been lasered quite well. Pan-retinal photocoagulation was described by Meyer Schuckerath in the 1960s. And there is hardly anything in medicine which has stood the 60 years of 60 years without contesting. Even now, a proliferative diabetic retinopathy, whatever our science has improved, a good tight laser PRP in time will save his vision in more than 60 to 70% of times. Yes, people who have lasered have bled later. Yes, about 30 to 40% of people will bleed. But if you did not laser, nearly 100% of them would have ended up in laser bleed. And this is a bleed. You can see that the retina and the vessels are all very, very poorly seen, and you can see some blood here. And this is a patient in whom multiple neovascular, you can see this neovascularization here, and there's a fibrovascularization here, and there is a bleed here, and there are hard exudates here. So these are all conditions in which we may consider an injection followed by laser. This is a patient who has a bleed in which his fovea is completely obstructed because of the blood. And because the fovea is completely obstructed, his vision has dropped down to almost negligible vision. So this is a patient in whom we may have to go in, operate, take out the blood, and give him back the vision. So in such patients, the prognosis is excellent. So you take the blood out and the patient gets almost near close to 90% vision. So this is again another case in which there's a bleed with a traction retinal detachment here. This is areas of bleed. You can see that the disc is very hazily seen with the vessels very hazily seen. Now, this is a patient in whom you have done a surgery and good results come. Like this is the patient in whom this is a post-surgical result. You can see that the vessels and the retina is now very clear. Right from 1/60, which is about 10%, he would move to about 80%. But some cases are more difficult. Now, this is a patient in whom vision is 6/6, but you can see the area of traction is there. But slowly and steadily, we will wait. And even at this point of time, his vision was very good when the traction was increasing. This is year after year after year. Finally, when the patient bled, then I had to operate him and give him back vision. So many patients, you can see that post-surgery, this is a patient with traction retinal detachment around the fovea. Post-surgery and laser, actually, it maintains good 6/6 vision. These are macular traction retinal detachments, and these are some of the surgical results again. So this is a patient in whom large traction retinal detachment and bleed is there. Post-surgical result, you can see that the vessels and the retina are quite well seen. Sometimes it's very difficult. This is a very, very florid neovascular eye, in which you can see that some resemblance of the retina is there. There are some folds, but at least he can maintain ambulatory vision in this. So neovascular glaucoma is another major problem which can occur in these patients, in which there is a sudden increase in pressure also. Those patients also will require injection followed by laser. So this is a nutshell about diabetic retinopathy, which is a surrogate marker for a lot of these things. I think I will take questions now. I think I have taken the half an hour, and I think I'll have to take questions. I think already some hands are up. George Kosi, sir.
Thank you, Dr. Gopal, for the excellent talk. Now, we learned a lot from your talk, and and the importance of carrying an ophthalmoscope with us. In my when I see a patient for the first time, I usually do a comprehensive test for ruling out the complications. And in my camps also, I get the help of an ophthalmologist. They always go for the test and all. So I'm happy to hear your talk, and it was an excellent talk. And now I call upon Dr. Rajalakshmi to conduct the question answer section. Thank you.
It was a nice talk, Dr. Gopal, and it was a very informative talk also. As we physicians, due to our busy schedule, we used to even when patient comes for the first time or during the follow-up, we never used to give much importance for the fundus examination. But when the patient comes on the first time itself, when you screen for diabetic complications and as a screening for regular screening, to some extent we can prevent the complications which leads to drastic blindness and leading to a poor life for the patient. So I used to mostly once in 3 months or 6 months, I used to give annual checkups for my patients. But I'm asking, you didn't cover about the pregnancy, how to screen.
Oh, yes.
Are any importance in screening fundus during pregnancy patient with diabetic?
Yeah, Adam, that's an excellent point, which I completely missed. Pregnancy is a fast forward. So you are clicking double fast forward. So if a patient, there are two situations. One situation is that, pregnancy-induced diabetes has occurred. It really doesn't create much problem. And before pregnancy, there was no diabetes, and pregnancy-induced diabetes will subside after pregnancy. Many patients are like that. Now, the major problem is when a IDDM patient or even an NIDDM patient, type 2 patient, when they develop a pregnancy. IDDM patients especially, because they are already about 10, 15 years or 20 years diabetic when they reach that pregnant area. And that is a point of time when they may already have a proliferative or very severe non-proliferative diabetic retinopathy. And during pregnancy, the numbers will actually, I think, it's about 10 years worth of diabetes which will occur in this 9 months. That is what we need to realize. And there will be rapid progression from one stage to the next. So proliferative diabetic retinopathy will bleed. If there is diabetic macular edema, it will worsen. So significant changes will occur. So if a diabetic patient who is a long duration diabetes is planning a pregnancy, I think it is important that an ophthalmologist also sees, and probably before the pregnancy, that patient is before the patient goes into pregnancy. But that's a utopian idea. It will never happen. So what I think second best would be, at least during a pregnancy when 3 months screening is there, definitely, or even immediately after the diagnosis of pregnancy, at that point of time, we can have an ophthalmologist evaluation, and 3 monthly we need to see, maybe every trimester. And if it is worsening, you can consider laser safely in pregnancy. You can also give a steroid implant in pregnancy because steroids are not at all contraindicated in pregnancy. Okay. But generally, we would avoid all that as much as possible unless it is actually vision threatening. Only if it is vision threatening, we will do all that, because anything that you do, finally, if any untoward effect occurs, because we ophthalmologists don't like to play at all. We like to play very, very safe. Unfortunately, that is a thing. So we will not be aggressive in diabetic pregnant women, but diabetic retinopathy is aggressive in those patients. And many patients, immediately after delivery, we will take them up for surgery, etc., because through the pregnancy, it is moved to that particular level. Thank you very much for asking that question, ma'am. I think there are a few questions in the chat box also.
Yeah. Okay. Very good.
Oh, no. Long-acting implants to release VEGF inhibitor. So that is a very, very interesting research question, sir, which befits this research body. Actually, long-acting steroid implant is there. There's a dexamethasone long-acting implant, which actually the effect will last for about 3 months. All right. So 3 months is the usual effect of a long-acting diabetic, dexamethasone slow-release implant. There is a drug called brolucizumab, which has come out now, which is called Pagenex. Brolucizumab, its molecular size is much smaller than the Accentrix and the aflibercept, etc. So since the molecular size is so small, the same volume can have much higher molar concentration. So the molar concentration of the similar volume of drug that which we inject into the eye, it is 12 times higher than the other drugs. So what happens is that its duration of action is about 3 months. So that's a single injection, which action in about 60% of patients, you can follow about 3 monthly injections, but it is more expensive. It's about 40,000, 45,000 per injection. Now, the next thing is, the usual ranibizumab and all those things, they are coming up with injectables or refillables. Like you have a printer in which the cartridge you are refilling the ink, you can have a refilling of the there is a small implant on the side of the eye, inside the eye, which we kept, and we keep on refilling the monoclonal antibody into it, after 3 months, 4 months. So that is another thing which has occurred, which is clinical trials were done, but I think that had a lot of complications. Okay, that had a lot of complications, and I think we have not moving into phase 3 trial in that. It's shelved. That program is shelved. So there are a lot of newer research which is going on to use topical medications or Ocusert or something which the patient can himself or herself do and have enough VEGF concentration in the back of the eye. So a lot of research is underway in that direction.
Okay, sir, thank you. Actually, I did not completely understand what you had presented. That's why I asked that question. I am Dr. George Koshi, and I am the person who posed that question earlier. When you said acting implants, I thought you meant VEGF inhibitor, but then later on during the talk, I realized you're meaning steroid, because you give that in situations where VEGF inhibitor is contraindicated.
Correct, sir.
Okay, thank you very much, sir.
So how many injections you will be giving, and till after 2 or 3 injections, this thing to get a positive result?
Yeah, I'll tell about that, ma'am. 1 second. Can you see the screen, ma'am?
Yeah. Yes, sir.
Yeah. So we have, let us say that this is the eye, and this is the lens, and here is the edema. Okay, I give 1 injection. The edema reduced to this much. Okay, so which means still from 500 microns, it may have reduced to 450 microns. My target is about 250 microns. Okay, so just like you will not be able to decide on the dose of an insulin in a patient with 300 blood sugar, 2 patients may require 2 dosages of insulin. Like that, how many injections are required to bring down this edema here? Next injection, it may fall down to this. The next injection, it may fall down to this. And finally, after 5th injection, it may come down to this. Okay, so this patient required 5 injections to reach this stage. There may be another patient in whom the edema was just this to start with. Okay, the edema was just this to start with. With 1 injection, it fell down to this. Okay, there may be another patient in whom 8 or 9 injections are required to have the same effect. So different patients require different number of injections. So it is just like the insulin dosage. So the number of injections is our insulin dosage. But
it depends upon how the patient responds.
Yeah, it depends on the patient response, depends on the duration of diabetic macular edema, the chronicity, the type of edema, like patients with high hypertension may have another pattern of edema in which the number of injections required may be more. Maybe the hard exudate quantity is more, so you require to have more injections to flush out that. There may be a component of ischemic vascular block in which with 1 injection, the significant edema reduces. So there are a lot of reasons why patients may have require different injections. So to iron out this, I told you that DRCR, Diabetic Retinopathy Clinical Trial Network, they did a large study in about 1,500 patients, and they found out that in clinical trial situation, to reach the best result, they required 9 injections in the first year, 4 in the second year, 2 in the third year, 0 and 0 in the fourth and the fifth years. But we will not be as stringent as in the clinical trials. We will be much more looser in the clinical side, in the real world situation. So we may require close to 6 injections in the first year, maybe 3 to 4 injections in the second year, and then but the problem is our patients don't get a very good tight systemic control as in clinical trial situation. So many times what happens at the second year and the third year also, the injection numbers don't go down as much as in a clinical trial situation. That is where you have to help us and control that. I mean, there's a very important thing. Like when I have 6 or 7 injections the first year, the patient gets tired. So then I prod the patient to say that, you control your diabetes really well. And next year, the number of injections is going to go down. And do you know what happened? I did a study to look at what is the hemoglobin A1C of our patients before the injections. And maybe after 1 year, what is the hemoglobin A1C? I had 1 unit drop. From 9.2, it dropped to about 8.2. That was my, more than 400, 500 patients results. Yeah.
So, we'll conclude.
I have one more question, sir. On the role of statin and fibrate with respect to diabetic retinopathy.
Yeah, excellent. So PGI Chandigarh had come out with an excellent paper maybe 15 years back to say that a diabetic retinopathy with a lot of hard oxalates, just with good diabetic control and these statins and fibrates, the diabetic retinopathy had significantly reduced. I mean, it is not about just clinical reduction, significantly reduced in a lot of patients, but it takes 6 to 9 months. But the problem is the predictability of who will improve and who will not improve is something that we cannot ascertain right now. So if you do only systemic control with good glycemic control, as well as a reduction of statins, a reduction of cholesterol with statins and fibrates, in about a lot of patients, definitely that is needed. But in patients who do not get a retinal treatment like injections or laser, sometimes what happens is that hard exudates may increase, plaque may come, irreversible loss of vision can come. So we right now don't have an idea as to systemic control will improve which patient and will not improve which patient. But definitely we will do that. Number 2, I wanted to actually look at the effect of significantly lowering the cholesterol level in patients with hard exudates to see if that will have a beneficial effect. But our ethics committee cut it down, telling that I think a significant reduction of cholesterol levels are associated with the risk of stroke, etc. I mean, that was the reason why I could not do that. Significant lowering means to the levels of less than 60, 70 cholesterols. That I think is not very good in the long term. So they cut it down.
So we'll conclude.
Suresh sir.
Yeah, I think like there is no more questions. We had a wonderful lecture with a lot of takeaways for all physicians. An excellent one. Sir, keep coming back and teach us more about diabetic retinopathy management in future too. I think it's time for us to wind up, and I thank you all. Thank the speaker and both chairpersons, and also all the participants for wonderful session this evening. Till we meet next month with another topic, I think probably we're ready now. Thank you very much. Thanks a lot.
Thank you very much, sir. Thank you very much.
Thank you, Dr. Gopal. Bye.
Thank you.
Thank you.
Thank you, sir.
Thank you, sir.